All right, thank you, Dr. Ware, for the introduction and for the kind invitation from you and Dr. Lafall and other members of the committee for me to appear today. It's a great pleasure to be here, and before I start, I do have a lot of slides, a lot of material, and I will try not to speak at sort of auctioneer levels. So I do encourage you, if you need to download the slides, and of course I'm happy to provide them if you miss a reference or a citation. But before I jump in, I want to recognize and thank my colleagues, the co-authors on this work, which will hopefully be in a peer-reviewed journal near you sometime soon, as well as in a public report that we will release hopefully during the summer. And these colleagues and co-authors have really been instrumental in getting us to this point and developing these metrics, which will hopefully go towards informing the public health evaluation of regulation in Canada. Some of the colleagues, of course, are here today in the room, including Dr. Ware, Dr. Saw, Dr. Fisher may still be here, and most importantly, the soon-to-be Dr. Stephanie Lake, the first author who's really the driving force behind all this, who, despite the misfortune of having to work with me at UBC, has really is producing a lot of great cannabis science. So let's get going. Before I do the disclosures, of course, I received peer-reviewed funding from the American, British Columbian, and Canadian governments, as well as a gift from a private firm seeking a license to produce medical cannabis, although, of course, they had no undue influence on what I'm about to tell you today. And a lot of the subtext, I think, for what I've heard over the last day and a half, and a lot of the really great presentations, was about what's going to change, trying to imagine and trying to predict what will change in our clinical practices, in our research, in our communities, in our families, once cannabis prohibition is removed and cannabis regulation is enacted. And I'd like to really try and add to that conversation with our work here, in which what we're going to do is propose some possible metrics to evaluate on a population level the possible harms and benefits that we'll see after cannabis regulation. And I think it's important to start with a recognition that one of the defining sort of hallmarks of the prohibition system is around what the measures they use to define success and failure. This is a report from the UNODC, the international body in charge of securing a drug-free future, in which they talk about their work with cannabis. And you can see on the very first page that the measures they use are about drug supply, drug demand, and drug enforcement. They estimate that there were 183 million people in 2015 who used cannabis, and 164 countries reported that they had eradicated supplies of cannabis. Next slide. Not working. Next slide. This always happens. There we go. And the very next page, they have very similar metrics, talking about the success of enforcement efforts to eradicate crops, to arrest people who are selling cannabis, and to try and reduce or remove the supply of the drug. And it's important to note that by Prohibition's own measures of supply and demand, its efforts have been a failure. This is data from the US government showing in the blue lines the amount of dollars in billions that they have spent between the 1980s and the 2000s trying to control, through suppression, through enforcement, the use of cannabis, the use of all drugs. And we can see in the green line what has been one of the results of that. The price on street-level heroin has declined, while the potency of street-level heroin has increased. So even by their own metrics, Prohibition has been unable to reach its goals of a drug-free future and eliminating illicit drug use. For this reason, and for many others, the Liberal government in 2015, of course, the Liberal Party in 2015 promised that they would seek to legalize, regulate, and restrict access. And we are, of course, now on the eve of the implementation of a public health framework. And as a part of that public health framework, what we argue is that we need new measures to understand the impacts of this policy on the health and well-beings of Canadians, both at an individual and a community level, but also, maybe most importantly, at a population level. To date, A lot of the debate has focused on possible harms of cannabis legalization. And what we did at the very outset is propose that we want to look at both the harms of cannabis use, but also the possible benefits that we might see on a population level of the switch from prohibition to legalization and regulation. So with our study, we had the objective of reviewing the scientific literature to try and come up with ways of measuring this impact on a population level so that we can see what the impacts of legalization are and we can inform efforts to try and mitigate these harms and promote, where possible, the benefits of cannabis regulation. So today I want to try and do three things. One of them is just to sort of talk about this work and talk about what the actual metrics are, 28 different measures in 5 topics. And then to try and look into a bit of a crystal ball by looking at the preliminary data, the evidence that we see, especially from the United States, areas that have already enacted regulatory systems to legalize the non-medical and medical use of cannabis by adults. And then finally, I want us to end by sort of talking about what are some of the gaps that I see in the epidemiology of cannabis use and how we might go forward to improve this in the future. How did we do the review? How did we come up with the measures? Quite an obvious and a simple method. We reviewed a number of large biomedical databases looking for peer-reviewed articles that discuss elements of cannabis use and public health. We focused on the period from 2012 to 2017 to ensure that we were focusing on the most recent and relevant data. And what we did is we included studies looking at the impact in humans, and we eliminated studies that looked either at preclinical data, looking at specific cannabinoids, or looked at the clinical management of certain conditions. So we're really focusing here on the public health evidence and what the public health evidence says about the possible impacts of cannabis regulation. Once we searched the databases, we came up with a long list of titles and abstracts. We reviewed those and then reviewed the full text to see if the articles matched our inclusion and exclusion criteria. Then we grouped the measures into different topics and did further searches to come up with both sources of data as well as preliminary evidence. All of this stuff, including citations, including the measures themselves, including sources of data, will be available in the public report. And so I'm looking forward to inviting you to be able to review that when it is released. So turning quickly to the results, what did we find? We came up with 28 different ways to measure cannabis regulation, and we grouped them into sort of 5 topics, 5 general domains that we thought were important to measure over time. And the first one is public safety. And obviously there's been a lot of discussion today and yesterday, as well as in the last number of years, about the possible impacts of regulation and legalization on road safety. Obviously, cannabis intoxication can interfere with many of the skills necessary for the safe driving of a motor vehicle, and existing data does suggest that this is a not uncommon behavior among some people who use cannabis. And I'll switch to the other clicker. There we go. So here are the first 5 indicators that we came up with. And very simple, straightforward population level measures of road safety, looking at things like the prevalence and frequency of cannabis impaired driving, looking at the prevalence of motor vehicle related injuries and fatalities involving cannabis, and also because we are aware of some evidence to suggest that the cannabis regulation might change the consumption of other psychoactive drugs. We also believe it's important to look at all-cause traffic accidents as well as traffic accidents involving alcohol. What do we know about the preliminary data from the U.S. In areas that have already legalized cannabis? And I'm playing sort of roulette with these things, and here we go. So this is the first paper, and this is a very preliminary paper from the toxicology lab at the Washington State Troopers. And they found, not surprisingly, that before legalization, approximately 20% of drivers who were suspected of impaired driving had THC in their systems. After that, the prevalence of detection increased up to about 25%. Similarly, among decedents, people who were driving and who suffered a fatal motor vehicle accident, we see that the detection of THC increased after legalization from approximately 8% to almost 25% of decedent drivers. Now, I want to underline that the detection of THC in the bloodstream does not correlate with cannabis intoxication. Because, of course, cannabis can be, or THC can be detected up to 28 days after exposure, all this data indicates is an increased prevalence of exposure among these drivers. And we cannot conclude that there were increases in intoxication leading to car crashes, motor vehicle accidents. Perhaps because of that, the preliminary data from Colorado and Washington State has not shown any large significant increases in motor vehicle accident rates. This was a study published last year and showing change in the rates of motor vehicle accidents before and after legalization. And there's no significant difference in Washington and Colorado on the all-cause rates of motor vehicle accident before and after legalization of cannabis. No evidence to suggest that legalization has led to a degradation of road safety. There is, though, interesting data to suggest that the liberalization of cannabis laws might, in fact, contribute to improvements in road safety. And this was another paper published in AJPH last year looking at rates of traffic fatalities in the United States by state from 1985 into 2014. And what they did is they compared rates in states with some form of legal access to cannabis, either medical or non-medical, to states that had no such laws. And they looked at this over time in a longitudinal design. And long story short, after adjusting for a lot of other possible explanations for differences, they found that living in a state, or states with some sort of legal access to cannabis, had 11% lower rates of fatal motor vehicle accidents compared to states that had no legal access to cannabis, either medical or non-medical. Now, that's an ecological study, obviously, but I think in terms of the evidence, that's all we have to date about the possible impacts in Canada. We also, of course, looked at a number of other measures of public safety which we believe will be important, which the literature tells us there may be some differences pre- and post-legalization. This includes the prevalence or rates of interpersonal violence, especially intimate partner violence, looking at cannabis-related workplace injuries and fatalities, as we've heard a lot in the last excellent presentation, and of course looking at rates of crime before and after legalization. There's not much data here. There is some data from Colorado and Washington State showing obviously substantial declines in arrests for low-level cannabis crimes. And there are also data to suggest that homicide and other forms of violent crime are also decreasing. There we go. But these decreases in violent crime and homicide are consistent with longer-term trends, and at least in Colorado, there's been no apparent change in rates of violent crime after legalization. Now, turning to our second broad topic, and that is cannabis use patterns, and obviously cannabis use among youth, which is something I can never say without tripping over my tongue, is reducing those rates are a prime objective of the policy of legalization. And as Dr. Fisher, of course, outlined this morning, there are concerns that legalization and commercialization could lead to an increase in cannabis-related harms through factors like increased prevalence of use, increased use of high-potency commercial cannabis, which is something that we've seen as other plant-based psychoactive drugs became commercialized, and of course, increased use among people who are already vulnerable to suffering cannabis-related harms. At the same time, I think it's plausible to think that the implementation of a public health framework could have benefits with regard to cannabis use and cannabis harms. For example, access controls in government stores could lead to an increase at the age at which people begin to use cannabis. As Dr. Fisher has helpfully pointed the way for us, the public health framework will allow and promote the promotion of lower risk cannabis guidelines. And of course, it may have, the public health framework may have benefits in terms of lower exposure to contaminated cannabis and greater adoption of cannabis for which all impurities and contaminants have been screened out. So these are our indicators for cannabis use. We suggest that there are 4 things we should be looking at after legalization to try and understand what impacts it has on public health. Obviously, the incidence and average age at initiation will be an important indicator going forward, as were usage patterns among use. And as well, of course, cannabis use disorder, which is currently estimated to be around 5% among people who use cannabis, will be an important measure going forward to judge the impacts of legal cannabis on use and harms. As well, it will be the prevalence of use of unregulated cannabis or cannabis from illicit producers. What do we know so far, especially about the use of cannabis by youth after legalization? This is data, again, from Colorado and Washington, in which they used surveys of people in schools to try and understand levels of cannabis use. And I think the short story here is that there's no obvious trend apparent. A lot of these changes are within the margin of error. There are some increases, there are some decreases, but I think the idea that the legalization of cannabis will lead to sudden and substantial increases in youth use, I think are definitely not supported by the evidence. In Washington State, the prevalence of last 30-day use increased amongst 8th and 10th graders, but not 12th graders. And in Colorado, they saw no significant differences among youth who were surveyed. There have been declines in treatment for or admissions for cannabis use disorder in Colorado and Washington. And unfortunately, we have no data on the uptake of licit cannabis and the use of unregulated cannabis in these settings. Here are the other indicators that we believe are important to follow over time, having to do with cannabis use. 2.5, we feel it's very important to look at trends in how people use cannabis, what specific products and practices, i.e., for example, the route of administration. We also believe it's important to look at the use of cannabis among vulnerable populations, especially people who are expectant or breastfeeding. And of course, looking at cannabis-related healthcare utilization, both from acute exposures as well as from chronic concerns. And as well, we should be measuring the classic public health measures of cannabis-associated disease and disability, such as mortality and disability-adjusted life years. What do we know from the preliminary data from Colorado and Washington? Well, there is some good news here, especially around how people use cannabis. And it suggests that the reform of cannabis laws is associated with better practices from the point of view of route of administration. So this is a survey administered to about 3,000 people on social media, so obviously there are obvious limitations to this approach. But what it said quite clearly was that people living in states with some form of legal access, either medical or non-medical, were much more likely to use cannabis by vaping or by eating compared to smoking. So that obviously is good news and suggests that maybe some form of public health regulation is associated with uptake of these lower risk guidelines. What about unintentional pediatric exposures? Again, this is something that's received a lot of attention, both in the media and among our policymakers. And there is quite clear data to suggest that the number or the rates of unintentional pediatric exposures to cannabis in Colorado have certainly increased dramatically between 2009 and 2015. The rates were already significantly higher than in other US states, but certainly the change here is concerning. However, I do want to point out that the cases, although concerning, were relatively modest. None resulted in a fatality, and the exposure to the healthcare system, either the emergency department or the ICU, was relatively short-lived, measured in hours. Obviously concerning for the parents and children involved, but not something I would argue that is of great public health concern at a population level. So what do we know about the preliminary evidence on acute harms? We are seeing, at least in Colorado, increases of these rates, but fortunately the number and the severity of the cases remains modest. And it's important really, I think, to understand the context of where we are now and understand the extent to which cannabis is associated with morbidity and mortality among Canadians at the moment. This is probably the classic paper in the field, again published by Dr. Fisher and his group here in Toronto. And what they did is they used attributable fractions, a public health measure of the association with disease, to try and estimate how many Canadians might have been afflicted with disability or death associated with cannabis use. And really the take home here is that there is obviously death and disease associated with cannabis use, but it is relatively modest. They estimated that approximately 200 individuals in 2012 died of cannabis-related causes, the majority from lung cancer, and of course, as we know, the evidence around the effects of cannabis on lung cancer is still quite controversial and believed to be much less of a risk associated with non-smoking routes of administration. And it's important, I think, to keep it in a context, and that context is the use of other substances. This is a bit of an older data set from the Canadian Centre on Substance Abuse, but it paints quite a clear picture, comparing the direct social costs associated with cannabis use versus the use of other substances. And you can quite clearly see here that when it comes to the direct social costs at a population level, the problem in Canada is not cannabis, it is alcohol. And indeed, the burden associated of morbidity and mortality associated with alcohol and other illicit drugs far outstrips that associated with cannabis. So I guess the conclusion is obviously we should be monitoring the public health use of the public health impacts of cannabis over time, but in the context of other substance use, we're starting from a context where the costs and the burdens are relatively modest, certainly in comparison to alcohol and other drugs. And now I'm going the wrong direction. There we go. And that really leads to our next topic, a topic that has certainly got a lot of us excited, as Dr. Lafall sort of outlined, is what might the effects of cannabis legalization be on the use of other psychoactive substances. And it's quite clear, we all know, that the use of other substances, alcohol, tobacco, and other illicit drugs, is associated with a devastating burden of morbidity and mortality. I come from a province, British Columbia, which is suffering through the second or third year of a public health disaster resulting from the contamination of the illicit opioid supply with fentanyl. And I would argue indeed that what we are living through at the moment is indeed a national public health catastrophe. Fortunately, as Dr. Lafall so ably outlined, there is very encouraging preclinical data suggesting that the endocannabinoid system is deeply implicated in several very fundamental processes, physiologic and psychologic processes related to dependence, to pain, to trauma, to depression and anxiety, a lot of the comorbidities that we know underline illicit drug use and illicit drug use addiction. And we are even seeing preliminary data from my group in British Columbia, as well from other groups in the United States, suggesting that individuals who use other drugs are using cannabis intentionally as a harm reduction strategy to try and reduce their risk of overdose and other harms. So these are the indicators we believe it's important to look at. Obviously, we want to look at the prevalence of opioid use, illicit opioid use, and opioid use disorder. As well, we think it's important to focus on the impact, the possible impact of legalization and regulation on fatal and non-fatal drug overdoses, as well as the prevalence of other forms of substance use and other forms of substance use disorder, including stimulants, alcohol, and tobacco. Come on. Nope. Doesn't like me. Doesn't like anyone? Yeah, no, I know. Yeah, there we go. Okay, so what do we know? What's the preliminary data? Well, there is some preliminary data, starting with alcohol, to suggest that in the US, the reform of cannabis laws has been associated with declines in the sales and presumably the consumption of alcohol. This is data from a group of economists, and despite that, I'll believe it. And what they do is, my apologies to any economists, I was raised by historians, I have to make the joke. What we are seeing here are data from sales data from retail scanners, showing that there appear to be declines in the sales of beer, as well as wine and other kinds of alcohol following the legalization or the liberalization of cannabis regimes. We also see, of course, and this really here is the paper which got a lot of us in the field of drug use and opioid use excited, by Bachhuber and his colleagues in 2014, looking at the possible impacts of the reform of medical cannabis and non-medical cannabis laws on rates of opioid overdose in the United States. And similar to those traffic studies, what they did is they looked at rates of opioid overdose over time within US states, and they compared states with some form of legal access to cannabis to states without any legal access. And when they produced that statistical model, and you can't see the text, it's quite small, they found that by far the biggest effect associated with the rate of opioid overdoses was the presence of a medical cannabis law. In states with a medical cannabis law, the rates of fatal opioid overdose were 25% lower than states without some form of legal access to cannabis. And that they also looked at other possible structural interventions that have been widely suggested to deal with the opioid crisis around reducing the number of opioid prescriptions, making it harder for people to get opioid prescriptions. And they found that these structural interventions, in many cases, had no statistical impact or had very modest effects. So here what we're seeing is evidence to suggest that making cannabis easier to access, making medical cannabis easier to access may indeed have a very beneficial impact on opioid overdoses, especially for people, I would imagine, who are suffering from chronic pain or any of the other comorbidities associated with opioid use. As Dr. Lafall pointed out, we're even seeing some indication, some very early indication, that legalization might have a direct impact on opioid overdoses. This is the slide he showed looking at the number of opioid overdoses in Colorado. You can see a pretty steady increase from the early 2000s to 2014, and then the beginnings of a decline after 2014, after Colorado legalized the non-medical access to cannabis. This has led many of us to be very excited about the possibility of using cannabis as a strategy, as an intervention to try and mitigate the risk of opioid overdose and to try and quite literally save the lives of people who we are losing to opioid overdose every day across the country. This was a paper published last year by Philippe Lucas at UVic, and basically what he did is he laid out a lot of the preclinical and observational data supporting the idea that there is some sort of rationale for cannabis-based interventions in the opioid crisis. And he suggested that there's really three areas of research that should be immediately and urgently looked at. Seeing if we can implement cannabinoid-based therapies prior to people initiating opioid treatment for chronic pain. As Bernard Lafall has so ably demonstrated, talking about cannabinoids as an opioid dose-sparing strategy, both in the context, I would argue, of chronic pain and opioid substitution therapy, and looking to see if it could be an adjunct to those therapies, such as methadone and Suboxone, to keeping people on treatment longer. In one of my studies in Vancouver, which follows people with opioid use disorder over time, we have seen that people who are starting methadone and Suboxone, who tell us that they are using cannabis every day, are statistically more likely to still be on methadone and Suboxone 6 months later. This paper is currently under review. We're hoping it's going to be published soon. And I believe it's another piece of evidence that is rapidly accumulating, pointing to the real need for a clinical trial. To try and answer some of these questions in a rigorous and well-structured way, to see the extent to which cannabinoids could indeed be a useful strategy to trying to mitigate the largest and I think worst public health crisis of our time. So, other substance use. The preliminary data is there's some good data to look at the substitution effect. Unfortunately, we don't have much data or any data on the possible impacts of legalization on tobacco or stimulant use. Cardiovascular respiratory health, there are concerns that obviously smoking of cannabis or cannabis-induced tachycardia can injure the cardiovascular respiratory system and may in fact be a risk factor for cardiovascular respiratory disease. Unfortunately though, so we are suggesting to look at several of these measures over time to see if things change for the worse after legalization, but unfortunately there's no preliminary data. And finally, our last topic is mental health and cognition. As we all know, there are lots of concerns about the fact that there are consistent associations in the literature between cannabis use and various psychopathologies. Although I think, certainly as an epidemiologist, I think that the case for causation has really yet to be proven. And that the associations, at least in observational data that we've seen, for example, between youth use of cannabis and later mental health outcomes are often quite substantially confounded by other determinants like other substance use, as well as social and structural determinants of wellness. And I think we also have to recognize that certainly for people who are using cannabis therapeutically, treating these sorts of chronic mental health concerns like depression and anxiety and PTSD are often one of the reasons that they are using medical cannabis. So while the science remains unsettled about the true causal nature of cannabis and psychopathologies, though, I think it remains important on a public health level for us to monitor the possible impacts of legalization on these conditions. And so we have suggested these 4 measures, including the incidence and the prevalence of psychosis and psychotic disorders, looking at the prevalence of depression and anxiety in our population, and of course looking at cognitive functioning and educational attainment among people who are youths. Let's try the other one. Nope. One more time. Nope. It's tired. It's tired. I know. Go to my next. There we go. Preliminary data. Very little preliminary data. These are obviously chronic outcomes which take many years in most cases to develop. So there's not much sort of preliminary data about the possible impact of legalization on these outcomes. This is the only data that we could find reporting on educational tests, standardized test scores among students in Washington State before and after legalization. You can see improvements in the scores of 8th graders after legalization. So good news, legalization made 8th graders in Washington State smarter. Draw your own conclusions. But obviously, I think this is yet more evidence that correlation does not ensure causation. So, to conclude, here we go. This is what we did. We reviewed the scientific evidence to try and come up with a suite of evidence-based indicators to inform the evaluation of the impacts of legalization. We came up with 28 indicators. And I think the good news is that when we look at the preliminary evidence from the United States, keeping in mind that we are in many ways quite different from our American cousins, there is some data that suggests that there may be increases, especially in acute hospitalizations, but little data so far on the impact of chronic outcomes. And that we are seeing quite promising data suggesting that there might be possible benefits, especially in the areas of the substitution of cannabis for the use of other higher risk substances. The good news, speaking as an epidemiologist, as a public health professional, is that we already have some good data that's in the field or has already been collected, which will allow us to measure the changes over time. Our friends, of course, in Ottawa have been quite busy. There is already a lot of data sources that they collect, such as the Canadian Community Health Survey and the new Canadian Cannabis Survey, which will allow us to do some of these sort of population-level analyses. But I think we have to keep in mind as well that while these are valuable sources of data, they do suffer from limitations. I think there are questions about, obviously, in the age of cell phones, adequate survey representativeness, and of course, I think there is also a question as to whether people will feel more able to answer truthfully in the public health era than in the criminalization era about their cannabis use patterns. And I think these are sort of survey and study biases that we should keep in mind. But I think the really important concern to my eye as an epidemiologist, and this is certainly something that Dr. Ware has pointed out many times in the past, is that as cannabis scientists, we still really lack a good, validated measure of cannabis use. And in drug use epidemiology, there's no truer axiom than the dose makes the poison. For one person, a dose of opioids may be therapeutic. For another, it may be fatal. And certainly with cannabis, we have a lot of measures which are useful, such as the frequency of last 30-day use. But these measures, while useful, are relatively unidimensional and do not capture all of the different nuances of exposure to cannabis, be it frequency during the day, being it time of day, being it route of administration, being it the exact type of cannabis used. And so I think there's a lot of good work that needs still to be done to come up with better measures that encompass all of these different aspects of exposure to cannabis. As well, I think we have to pay very close attention to whether or not the screens that we use in both research and clinical settings to try and pick up cannabis use disorder will remain valid. Many of the items on tests like the Cannabis Use Disorder Identification Test look at things like how much time did it take for you to get cannabis today, or how much time did you spend trying to get cannabis, and the levels of social stigmatization that I think might fundamentally change after we're able to go to a government store on the corner and buy cannabis just like we buy milk and bread. adults, obviously, only. So I think what we have to do is keep our eye on whether these diagnostic and clinical measures will remain valid and how we might improve them, especially to try and incorporate the intentional use of cannabis for therapeutic purposes. So to conclude, what we tried to do was come up with a suite of measures that will be useful in the future evaluation of the public health framework. And I think, echoing many previous speakers, we are very fortunate to live in this day and age, to be researchers and clinicians entering into this bold new future. And I think we have a responsibility, not only to our colleagues in other provinces and other countries, but most importantly to people who are using cannabis and using other drugs, to do good research, to try and understand the harms and the benefits of this new framework. We have some work to do methodologically, but I think that fortunately we have a number of good data sources, and obviously looking around this room, a number of great clinicians and researchers to ensure that in the new era of public health, we are measuring and evaluating based on good public health measures the impact of cannabis on ourselves, on our communities, and our society. Thank you.